Hi everyone, welcome to Radiologic Technology. So we're going to break down X-ray essentially and go through some of the information about how it was invented, how it's used today, and kind of the progression of everything in between. So to start, we need to learn a little bit more about the history of radiology and where it came from and how far we've come. So going back, like I said last week, X-ray was discovered by Wilhelm Conrad Röntgen on November 8th in 1985. So Röntgen was actually in his lab in the University of Würzburg in Germany. So that's where he was at. He had his PhD. He was working late one night in his lab, and he was actually investigating a cathode ray fluorescence tube. So what he was doing was he was passing electricity through those tubes, which were actually filled up with a special rarefied gas. So kind of think along the lines of like a fluorescent light bulb. In modern day times, he was kind of working with a simple version of that. So while he was working with that cathode ray tube, he noticed that there was a strange glow coming from this screen that was laying on a nearby table, and it actually had a piece of cardboard on top of it. But even with that cardboard as a barrier, it was still glowing. So he started to investigate that for, all day and night for weeks. He kind of hypothesized that the tube was emitting an unknown ray. So it's kind of invisible to our naked eye. But it could penetrate solid objects. So he was really, really interested in this. He actually named it X-rays because X is the mathematical equation for the unknown symbol. So that's where he kind of came up with the idea of X-rays. When he first decided to publish it, he submitted his discovery on December 28th, 1895, so weeks later from when he first initially discovered it. And he was actually met with a lot of people that disbelieved it at first. They thought, oh, he's crazy, there's no way. So he was met with a lot of disbelief, but a lot of people were really intrigued by this. They were interested. They wanted to see if this was really possible or not. So in less than a year, by January 1986, there was thousands of articles that were published and 50 books already. So he went over this and worked for, quite a long time on it. He actually won the Nobel Peace Prize for his findings in 1901. He received $40,000 from that prize, from the Nobel Prize, but he decided to donate it all back to his university. He believed that X-rays belonged to all of mankind. Even though a lot of his colleagues and friends and family wanted him to patent it, he didn't believe that that was the right thing to do. Imagine if he had. Imagine the slow growth that would have came from that. He realized the potential of X-rays and wanted to share it with the world. That $40,000 that he received from the Nobel Prize is equivalent to today's money, would be about $1.2 million. And like I said, he donated it all back to his university in Germany. So by 1896, Boston actually had 5 X-ray machines for medical use. The first hospital in the USA was in Boston to have them. You could actually order them from a catalog in the US in 1986 for $15. A big leap from what they are now. So, like I said, he had all that money that he won from the Nobel Peace Prize, but he donated it back. He didn't make any money off of X-rays. Röntgen actually died in 1923 at the age of 78, and he was completely broke. He had poured all of his money back into his research. Again, here's a picture of Wilhelm he was born in 1845 and he died in 1923. And again, here is a picture of that first X-ray ever taken. This was his wife's hand, remember, Bertha. So about 2 weeks after his initial finding on that night where he saw the screen glow, he actually took this first X-ray. So it was about 2 weeks after November 8th. And again, this image is a little clearer than the one I showed you before, so you can actually see the outline of her hand, and you can see her ring right here as well that she had on. So it's pretty impressive to think just 2 weeks later, this is the first x-ray ever taken. It's not anywhere near what they look like today, but it's still very impressive. And honestly, anybody that disbelieved it after seeing these first x-rays, I mean, he had the proof that was necessary. So think about it just for a second. Back in 1881, President James Garfield died from an assassination. The reason that he died was largely because he was shot and they couldn't find the bullet. So in 1895, after Röntgen discovered x-rays, this was a huge thing. They were able to find bullets, find anatomy, find disease, find things that were going on with these patients that prior to this they never knew. They used to have to go in for exploratory surgery and look around. Imagine that in today's day and time. If you had something going on and your doctor couldn't figure it out, and they actually had to cut you open to find out what was going on instead of just taking a simple x-ray. This was an early x-ray equipment similar to what Röntgen was kind of working with. So this is the cathode tubes that I'm talking about here. They're connected to a source of power. This would be an image receiver, or the film back then. But this was the screen, in a sense, that was laying on a table nearby that kind of was glowing when Röntgen was working with that cathode tube. This is a slide of Marie Curie in a mobile x-ray machine. So does anybody know what Marie Curie is known for? If you said isolating radium, you are correct. So she is most famous for isolating radium in 1896, so a year after X-ray was invented. And she was also the first woman to win the Nobel Prize. However, a lot of people don't really know that Marie Curie was actually a big hero in World War I. So right around 1914, when the war was starting in France, Marie Curie stopped her work with radium. She had been working with it, and she actually put it in a lead-lined container, so to keep it from leaking the radiation out. And she traveled by train about 375 miles away from Paris and put her life's work in a safety deposit box in a bank. And she kept it there until the war was over. She didn't want anybody finding her work or anything happening to it. But she also decided that she had to do something. She couldn't just sit idly by while this war was going on in her country. So, like I said, x-rays were invented in 1895. Now it's 1914. But x-ray machines are still only in large cities. They're only in hospitals. So what Marie thought was she needed to get these x-ray machines closer to the battlefield so we could help these soldiers. So what she did was invented essentially a radiological car, which was a vehicle that contained an x-ray machine and darkroom equipment. This was huge. So those hospitals are a long way from the battlefield. A lot of these patients couldn't make it to the hospitals before they died. So this vehicle could actually be driven straight to the battlefields where the surgeons could use the x-rays to find bullets or find out where their injury is and help guide surgery. It was huge. It was beneficial to these soldiers. But to go back a little bit and start, Marie Curie, she utilized her status in the community and approached very rich and powerful women to help donate the money to get this to start. And she also asked them for them to donate their cars to be used as these vehicles. She didn't have the vehicles, she didn't have the resources, she didn't have the money, but she used her power and her status to kind of reach out to the right people, mainly women, to get them to donate everything so she could do this. She recruited 20 women and had 20 vehicles. She trained them to take the x-rays, to drive the vehicles, and fix the vehicles and the machine. So if they got flat tires, I mean, there was times where they actually tipped over and they had to right the vehicles, fix what needed to be fixed, and keep going. Not only did she do all this, but she also herself operated one of the vehicles in the battlefields, and so did her daughter. She also helped establish 200 x-ray rooms in field hospitals during the war, and it's estimated that over 1 million wounded soldiers received x-rays during that time. what an impact she had during that time in the war and how many lives she potentially saved. It's really amazing if you think about it. So x-rays were also referred to as radiographs. So you might hear that used interchangeably. The book says that they're also referred to as röntgenograms after Wilhelm Röntgen. Some people kind of coined that term. Röntgen himself didn't call them that. He called them x-rays. But other people started to refer to them as röntgenograms in the early times. That is not something you will ever hear today. So conventional x-rays has evolved over the last 100 years, but honestly the basic principle is still the same as we used it in 1895. I mean, they've upgraded the equipment, things have changed equipment-wise and new technology, but the basic principle is still exactly the same, and we'll break that down in a little bit in the slide on how it works. So some of the terms that we use, one, radiology, which is a medical specialty in which x-rays, radium, and radioactive substance are applied to diagnosis and treat the patient. So remember earlier, last week I guess, when I said they used to call them radiology departments, but now they're diagnostic imaging. This is why, because everything's not radiology. It's not radium and radioactive substances. There's other specialties within that department, which is why we use diagnostic imaging, which is a medical specialty in which X-ray, radioactive substances, sound waves, and radio frequencies are applied to diagnose and treat the patient. So diagnostic imaging is going to include ultrasound, MRI, nuclear medicine, bone density, X-ray, CT, all of them. Three other terms that are really important to be able to differentiate between are radiologist. A radiologist is the physician who reads the x-rays and will also perform some diagnostic imaging procedures on patients. They're going to perform the fluoroscopy procedures, they're going to perform biopsies, and things like that where we need a procedure done on a patient within diagnostic imaging. The radiographer is the skilled, qualified person who's providing the patient services using imaging as directed by a physician. So they perform those images. They take those images and then they pass them on to the radiologist. Make sure you know the difference between those two terms. And a radiograph is just a photographic record produced by the x-rays. So what's the pertinence to the medical community? Well, one, x-rays are quick, they're inexpensive, they're semi-portable, and they can provide evaluation of our bony structure, our bones, our GI system or gastrointestinal system, and our genital urinary system. So x-rays are essentially one of the fastest, easiest, and inexpensive ways for doctors to view our internal organs and our structures of the body, so they can help detect disease and illness and see what's going on. X-ray is huge in the detection and diagnosis and treatment of cancer. It's on the forefront of everything relating to cancer, from diagnosis using X-ray, ultrasound, CT, MRI, then to treatment using radiation therapy. A lot of people don't even realize this, but X-ray is actually an important part of bone density measurement too. So they're helping to detect osteoporosis in patients. So there's actually a scan that can be done that's a very, very low dose of X-ray. The patient just lies on the table and actually the technologist can stay in the room without any protection. That's how low a dose of it is. And they usually look at the spine and both of the hips and they can measure the patient's bone density to see if they have osteopenia or osteoporosis and kind of help determine what the risk is of this patient having their bones break from no injury. There's also a key role for orthopedic surgery. Orthopedic doctors, most of them actually have x-ray right in their office. And like I said before, most orthopedic surgeons don't even have radiologists view their images. They do it themselves. So they actually have their own equipment and a lot of times their own technologists right in their office, and they will x-ray patients. So they use it a lot for pre-surgery, so they can see, one, if the patient needs to have surgery, use those x-rays as a template to determine what kind of surgery they need and for measurement purposes to see how big the replacements need to be. And then they'll also use it post-surgery to see how everything looks. So general x-ray can be broken down into two categories. This is important to know. So general radiography is a still image, right? It's just a one-dimensional image of the anatomy that we're looking at. It can be bone, organs, anything like that. And it's shown on a film or on a computer screen. So general x-ray only shows the form of the anatomy. It's not going to show how it functions at all. So fluoroscopy, which is a movie, and I do have a little movie on JetNet under this module that will show you a fluoroscopy kind of image. So fluoroscopy is like a movie, which is made of an organ. So like for an example, if a patient's having difficulty swallowing, we can do a procedure with barium sulfate, remember, a contrast agent, that they can swallow that barium and we can watch it go down their throat, and we're watching it live and we can record that so we can re-watch it. So it's actually showing the function of how that patient is swallowing. It can show if they're aspirating, if something's getting stuck, if there's issues with the anatomy in that area, and it's all viewed on a TV monitor or a computer screen. So they can record it and go back and watch it. So again, very important to know, general x-ray shows the form of anatomy, but not the function, and fluoroscopy will show the function of the anatomy. We can watch things, I mean, it would be a long time, but we can watch things go from the mouth all the way down throughout the entire system into the rectum. I mean, that's a long process, but essentially we could if we wanted to. There's a lot of different types of radiography and fluoroscopy procedures that are available to help look at the anatomy and see how things function. So some of those examples are angiography, which is looking at the blood vessels, arthrography, which is imaging of the joints, barium x-rays, which they don't usually call them barium x-rays, it's usually fluoroscopy, but those are x-rays or fluoroscopy of the GI tract. Cholangiography, which is imaging of the bile ducts. You can't see the bile ducts on a regular image. They have to have contrast injected into them for you to be able to visualize that. A cholecystography, which is imaging of the gallbladder. Again, same thing. We can't just see the gallbladder on standard x-rays. There's dental x-rays, lymphangiography, myelography, which is of the spinal cord, urography, which is the urinary system, and imaging the kidneys and the bladder. So there's a lot of different subspecialties within radiography where we can look at specific anatomy or organs. So how does X-ray work? Well, the basic principle is X-ray uses ionizing radiation, but we can break it down a little bit more than that. So what happens is we have a powerful X-ray generator or an energy source that we turn on. Then we take high voltage that's applied to the X-ray tube. This is where the tube is where the X-ray energy is actually created. And then this will generate electromagnetic radiation. Then what happens is a tight beam is fired out of a small wire, which is called the cathode. And then it hits the anode. The anode actually has a tungsten-coated plate on it, which this causes the energy, the X-ray energy, to be released from the metal structures inside the tungsten. So then the X-rays are filtered and focused as they leave the X-ray tube. Then what happens is the X-rays are going to pass through the body part of interest and record on an image receiver. An image receiver is anything that's going to receive that image. So it can be film or it can be a digital kind of plate that we use now more today. So back in the film days, there was actually a special phosphor coating inside the cassette that would glow and then expose the film. That would be called a kind of like a latent image. The resulting film would then be developed much like a regular photograph. So we would have dark rooms. We would take the image, it would end up on the film, we would go into a dark room, and we would process that image. Back in the very beginning days, you dip it into the different chemicals, and then they made processors where you would just run the film through and it would process all of it for you. So that's kind of, everything that's changed through the years is going from film to now what we have is just digital images. So when an X-ray is created, an X-ray beam passes through the patient or the body part that we're looking at, and it's picked up by that detector or image receiver on the other side. So what happens is those X-rays kind of come out of the tube, they're directed towards the patient, and a portion of those beams are going to be absorbed by the body part, but other beams are going to pass all the way through the patient onto that image receiver or film. What happens when they pass through is they cast kind of shadows of that anatomy, and the tissue, which are going to create that image. So, for example, as the X-rays pass through a hand, they are attenuated or weakened or absorbed by different densities that they encounter. So if we think about the different densities we might have in a hand, we've got bone, muscles, and tissue, right? So bone is very dense. So what's going to happen is the bone is actually going to absorb or attenuate more of those X-rays. And the soft tissue surrounding it is less dense, so it's not going to absorb as much. So it's these differences of the absorption between the bone and the soft tissue that actually help create the image or cast those shadows. So when we look at some of these things, how different body parts attenuate the X-rays, bone is more dense, right? So it's going to attenuate more. So bone is going to be white on the image. Soft tissue is going to be less dense than bone, so it'll attenuate just a little bit less. And soft tissue and muscle kind of look gray. And there's a varying gray scale that we use, but there's going to be different variations of gray for the soft tissue. And air is not dense at all, so it's not going to attenuate much X-ray, so it's going to be black on the images. So keeping with the how does it work, we have a machine which uses that ionizing electromagnetic radiation. We have a tube, and we have an image receiver. We also need a patient, so we can position the patient to get the correct images that we need. And then we also need to use proper techniques to produce an adequate image. There's actually quite a bit of science that goes into how much voltage, how much power we use, and then how much dose we give the patient to get an adequate image. And then we have the radiologist that interprets these images to help kind of diagnose everything. So here's the inside of an X-ray tube. So you've got this is the tube housing here. It was glass. So you have the power source comes in over here on this end here to the cathode. There's this metal wire that I was talking about. So the power source is turned on, and then what's going to happen is that high voltage is applied here, and then the X-ray energy is created. It comes through and it's fired out of this small wire in the cathode, it's fired out of this cathode, and then what happens is it travels over here and it hits this anode. Remember, it has that tungsten plate on it, and then what happens is that directs the X-ray beam out of the tube and directs it towards the patient. And here's kind of another example. So here's the tube, and then what happens when it comes out of the patient is these are all X-ray beams coming down, and then we've got the patient here. So the X-rays are going to come through the patient. If you see here, 1, 2, 3, 4, 5, this is just an example. So they have 5 beams that are coming through the patient, but what happens is that patient absorbs some of those beams, right? And then you've only got 3 or 4 coming back out and actually hitting the image receptor. So these are going to kind of cast those shadows of the bone and the tissue onto that film or receptor, whatever it is we have that we're using. So again, as far as the machine, we have the tube, which has the anode and the cathode, and the collimator in it. What the collimator is they actually have lead shutters in there that can block radiation coming from the tube. The anatomy that we're looking at varies in sizes. So it could be, your entire femur to your pinky. We don't need the same field size for both of those, right? So what we have the collimator so we can narrow that field size down and block some of that radiation that's coming out of the tube, which is going to give us a better image, and it's less radiation for the patient. We also need something to operate the x-rays. So we have what we call an operating console, which is how we control the KVP, which is going to penetrate the x-rays. It controls the contrast of the image. And then we have the mass, which is the milliamperage, and the time. So that's going to control the quality of the beam, or the density. We're also going to have a table, a bucky, and an image receptor, and I've got some images that I'll show you of those. So here's the outside of a tube. The images that I showed you before, everything's kind of housed inside back here. So the anode and cathode are back here. This is what we use to actually control the machine. So I can use these buttons here to move this machine all around and center it over my patient. And behind this handle, you can't really see it. Underneath here is where those collimators are. I've got 2 dials that I can adjust those collimators to close it down so that the patient isn't receiving much dose. This is what a console looks like, an operating console. They're all different, but they all have the same essential elements. So you can pick the body part you're doing. You can change your your KVP, your mass, your time, all of those things. We control that for every single x-ray we take to ensure that the patient is getting an adequate dose. So we give good quality images, and we don't overexpose the patient and give them more radiation than necessary. This is kind of what the imaging console looks like. So I talked before about post-processing. So when this image pops up after we take it, there's things that we can do afterwards to kind of change the images. So we can go through and add markers, right or left, or say things about this image, whether it was taken upright or supine. We can trim or mask the image. We can change some of the image processing. We can magnify. We can invert, remember, and change the blacks to whites and the whites to black. There's a lot of different things that we can do here before we actually send it to the radiologist to read. This is an average x-ray room here. So you've got a couple things. This is the wall detector, so these are when x-rays are done standing up. You've got the tube here, and it's actually moved about on the ceiling so it can go all over the room. And then we have an x-ray table here. So this is an image receiver, and there's an image receiver under the table as well. So this is pretty standard. Most x-ray rooms, I mean, there's a million different types of x-ray rooms, but they all have very similar features. Here's a close-up of the upright image receiver, or bucky we call them. It's actually inside of here. So the x-rays are directed from the tube. They come through, the patient would be standing right in front of this, and then they'd be absorbed onto the image receiver that's housed inside of here. So when x-rays first started, we used film. Film is almost obsolete now. I mean, most of the hospitals now have either CR, computed radiography, or DR, which is direct radiography. And this is a plate here that we have that's direct capture. So this is an image receiver. So this is actually replaced film. You can actually put the patient's body part right on top of this. So you can put a hand, wrist, elbow, anything like that, sitting right on top of this plate and have the tube direct x-rays right over the top of it. It's very portable. We can use it on the patient's stretcher. We can take it right into the patient's room, things like that. So some of the patient or technical components, our patients are not going to be the same. Every patient you have is going to be different. And that's kind of one of the things that I enjoy about x-rays is no patient is the same. Every time I do a patient, it's going to be something new and different. So our patients obviously can be different in physical size. They can be really large or really small. And we need to be able to differentiate between them. We need to know our techniques and know how to take care of them. They can be young, they can be young or old. So, that's going to determine the difference in things. Again, with our technique, how we talk to them. We can't talk to a 2-year-old patient the same way we would a 70-year-old or a 20-year-old. We need to be able to assess them differently. talk to them differently. I mean, when we talk to a 2-year-old, we're going to, use our little sweet voice, right? Hi, my name's Stacy. I'm going to be taking your x-rays. Do you like stickers? Now, what do you think would happen if I talked to a 70-year-old patient like that, or a 20-year-old patient? They'd probably look at me like I'd lost my dang mind, right? So we have to adjust ourselves to each individual patient as well. We're going to have to deal with patients who have diseases, and that's going to affect a lot of different things. Some of the examples they have here are osteoporosis, emphysema, pneumonia. Those are only very basic things. I mean, we could have patients that don't have legs, so they can't stand for their x-rays. We're going to have to work around that. They could have a severe fracture that limits their movement, so we can't take the x-rays the way we normally would. So we have to adjust and compensate for that. The biggest thing with x-ray is you need to be able to think outside of the box. Not every patient is going to come in and be walkie-talkie. We're going to have to figure out a way to work around each individual patient and still get the best quality images that we need for them. That's kind of my favorite thing about this job is it's not always just simple. I have to really use my brain and think. And then when I can make it easier for that patient that's got a severe fracture and can't move, or I get a good quality image when I've had to adjust everything around that patient, it makes me feel good about what I just did. So there's a lot of different things that I really enjoy about that. Concerns as a technologist, as far as x-ray procedures go, we need to be concerned about their clothing. Depending on what they're wearing, we may have to have them change. If they have any metal on their clothing, buttons, snaps, things like that, we need to have them remove that because we don't want anything in the way of the x-ray. If we leave something on there, it could obscure the anatomy. And sometimes it can be like you're interrogating the patient to try to figure out. I don't know how many times I've said, okay, I need you to take everything from the waist up off, including your bra. I go in to do a chest x-ray and they left their bra on. So sometimes you can explain things to them perfectly and they still only retain a little bit. So a lot of times I will say it twice. I'll tell my patient, I need you to take everything off from your waist up, including your bra, put this gown on so the opening's in the back, and then just open the curtain when you're done. And then I say, so again, everything off from the waist up. If you have a necklace, bra, anything like that, everything needs to come off, and then put that gown on. But like I said, you can try as hard as you can, but some patients still aren't going to. They might forget that they had a necklace on. I mean, even me as a radiographer, there was a time where I had to get a chest x-ray and I forgot that I had my necklace on. I wear it every day, I don't take it off, so it just slipped my mind. But that can cause repeats in patients. And even simple things now, not to be too graphic, but underwear, especially women's underwear now, there is all kinds of crazy metal that shows up. I mean, I've had patients that have underwear where the rhinestones on their butt spell out things like, hey, hi, hello. Or they've got little dangly butterfly charms hanging right above the back side, or little heart, reflective material on the front. Those are things that patients don't really think about, but they will end up showing up on x-rays. So we need to really, interview them and make sure that they don't have any of those things on. Sometimes, it just will result in a repeat. We won't notice it until we take the x-ray, and then we'll say, hey, we found some metal on your underwear. I'm going to need you to go ahead and take those off. 2 words that are really important for you to remember are radiopaque and radiolucent. So radiopaque means that something does not allow the penetration of x-ray. So that's why it's so concerning with metal. Metal does not allow the penetration of x-ray, so it's going to obscure the anatomy. So if there's metal or other radio-opaque substances, it will obscure the anatomy, we won't be able to see it, and we'll have to repeat the image. Radiolucent means that it's almost entirely invisible on x-ray. So some of the things that we use that are radiolucent are like slide boards to help transfer the patient over, and we can actually leave them under the patient while we x-ray them. They're radiolucent. We have special sponges to help and aid in positioning our patients. Those we can put under the patient, and they're radiolucent, so we can x-ray through them. A lot of backboards and C-collars are partially radiolucent, so if we have trauma patients that come in on those backboards with a C-collar on, we can't take those off, so we can x-ray through them. They actually have new trauma beds as well that are radiolucent. We can put the image receiver right under the bed itself, and the mattress is radiolucent. So just remember the difference between radio opaque, which does not allow the penetration of X-ray, and radiolucent, which is almost entirely invisible on X-ray. So breaking down some of the cost between the three things. Okay, so film is essentially just like the film in a camera that we used to have. You would take one image on a film, you would process it, and then you would get your image. CR came out, and that was computed radiography, which you would have a plate, but you could still only take one image per plate. And then you'd have to process it and get another one. Still a huge, huge improvement from film, because instead of film taking about 1 minute to process each image, CR would take about 30 seconds. Then came DR, which is a matrix flat panel. And DR, you can take multiple images on the same panel. Imagine that panel that I showed you back a few slides ago. That is, let me flash back to it real quick. This is a DR panel. So I can take as many images on this that I want without having to change everything. So think of film as your standard 35 millimeter camera, right? You can only take one film. You have to process that before you get it. There's a little time lag in between it. CR is kind of like your Polaroid camera, right? You can take one picture at a time. It's still pretty instant, but it takes a little bit longer to process. You got to wait for that, you got to shake that Polaroid picture and get it to come up. I almost started singing the song. And then DR is like your digital camera or your cell phone even. So you can take as many pictures as you want, right? And there's a very small delay. It's only about a 3-second delay between when you take that exposure or take the image and it populates on the computer with a DR. So when you look at the cost, it seems like a huge difference. So cost for film is $1.50 to $5 per film. It's comprised of an emulsion layer, which is sensitive to light. So if a film bin ever got left open and they opened the darkroom door, all of that film would be exposed and useless. It had a polyester base and an emulsion layer. So it would have to be processed through chemicals, which could be dangerous. So we think about, oh, well, it's only, $1.50 to $5 per film. But if you think each individual that we're x-raying needs at least 5 films, that could be $15 per patient. So that's going to add up. A CR, like photo-stimulated luminescent screens, were about $20,000. It's a larger upfront cost, but it will pay for itself in a matter of time without having to spend, $15 per patient. And then digital x-ray that has those matrix flat panels, these can be retrofit, which means you don't have to buy all new equipment. You can get that panel to fit to your x-ray room. Those can cost anywhere from $60,000 to $140,000, which again sounds like a lot of money, but it is up front. But it'll again pay for itself in a short amount of time if we're not buying film, and all the other benefits that come along with it. With digital x-ray, the dose for the patient is substantially less. Our capabilities of manipulating the images are much more. So there's a lot of things that we can do. They can see a lot smaller densities or diseases or things that are going on the patients a lot sooner with digital x-ray. And we can x-ray more patients in a shorter amount of time because we don't have to wait to process all of those films. So film is actually becoming obsolete. It was still kind of common when I started x-ray 17 years ago. Some facilities still had film. A lot of them were going to CR. DR wasn't an option. DR is new now, and most facilities have DR systems. 3 of the most frequent exams that we do in x-ray are a chest x-ray, a lumbar spine, and an abdomen. So remember that in case you're asked at a later date what the most frequent exams are. Remember they are chest x-ray, lumbar spine, and an abdomen. These are the x-rays. So here's a chest x-ray. We can see the lungs here, right? So here's the two lungs, your right lung, your left lung. Remember, when we look at an x-ray, think of anatomical position. We're looking at the x-ray like we would be facing the patient. So this is the patient's right side, and this is the patient's left side, and there's a little L right here in the corner to indicate that. So you can see the heart shadow here, which is more on the left side. You've got the clavicles coming up, clavicle, clavicle, right shoulder, humerus, and here's the diaphragm with the base of the lungs. So remember, air attenuates less x-rays because it's not dense, right? So we can see the black in the lungs is x-ray. The tissue is gray, and then the bone, like the clavicle here, or the spine, shows up white. So you can kind of see the different attenuation levels or densities. So remember, with a chest x-ray, you can see the black air in the lungs. Now, this is an L-spine x-ray and this is an abdomen x-ray. When you look at them at first glance, they look very similar, right? But the difference is, for an abdomen, we keep the collimation open on each side to see more of the abdomen. Where on the lumbar spine, it's collimated down a little bit more, so we only have a small amount of space on either side of the spine. Again, here's a marker down here in the corner that says this is the right side of the patient. It's like we're looking at them in anatomical position. So if you're asked on any tests, possibly, to differentiate between an abdomen x-ray and a lumbar spine, you're going to need to know whether they're including abdomen and the entire bladder, or if they've collimated down to just include the spine and the sacrum. But like right here on this abdomen, you can see the kidneys, you can see the shadow of the psoas muscles, which are right here on both sides, and you can see the bladder down here. And again, this is marked in the right hand side of the patient. So the abdomen usually gets kidneys, ureter, and bladder. And we want to try to get the edge of the patient's abdominal anatomy as well. So when we talk about side effects, there really aren't many side effects in general x-ray. Immediate side effects, there's none. But there is the possibility of, if you have multiple exposures over your lifetime, that you could develop cancer or cataracts later in life. So that's why we don't want to use x-ray if it's not absolutely necessary, because we don't want to give that patient exposure to something that they don't necessarily need. Genetic effects and development of cancer are the primary health concerns that are attributed to radiation exposure. So some patients get really nervous about the radiation exposure. They don't want them. They're worried about getting cancer from it. They're worried. You'll get patients all the time. They're like, I've had so many x-rays, I should be glowing right now. You don't ever want to downplay the amount of radiation. However, a lot of times, to alleviate a patient's concern, I will tell them, just to let you know or give you a comparison for radiation, you're going to get more radiation on a flight to Florida than you would from a chest x-ray. That's true. It really is. A lot of patients don't realize that they're getting radiation when they fly. Elemental radiation. I mean, there's radiation all throughout our environment. It comes from the ground. It comes from your granite countertops. I mean, there's a lot of different sources of radiation that we don't even realize that we're exposing ourselves to. So, like I said, most of the time for general x-ray, there aren't any immediate side effects, but with the possibility of multiple exposures, you can develop cancer or cataracts later in life. Years ago, there was some serious side effects. The patients could have digestive disorders, nausea, vomiting, diarrhea. They could get blisters on their skin or severe radiation burns to where they would even lose their fingers or lose digits. And then it actually could result in death. This was very common, especially in the early stages, because after Röntgen developed x-rays, they really didn't know the harmful side effects to it. He himself actually used lead barriers, but a lot of people, especially like Marie Curie and her women who worked, they had a lot of side effects from it because they didn't use protective measures like lead aprons or lead walls. Lead will actually protect us from x-ray. And when you go into an x-ray room, The doors are lead lined, the rooms are lead lined. There's lead glass protecting the radiographer from the patient while they're taking x-rays. We have a lot of things in place now that are keeping us safe that in the beginning of time they really didn't know. And even when they did know, the old equipment required a much higher dose than what we use now, so it could cause more of those effects. Safety. There's a lot of things that we need to worry about as radiographers during examinations to ensure the safety of the patients and ourselves. So the first thing is pregnancy. We don't want to x-ray a woman if she's pregnant. Now, there are extenuating circumstances and times when we do. I have x-rayed a couple pregnant women in my life. We will x-ray for extremities and things like that to check for a fracture if a woman's pregnant, and we would just double shield her with a lead apron to make sure she's fully protected. But there have been a few times where I've actually had to x-ray the abdomen with the fetus in it for serious reasons. But we'll x-ray a chest x-ray and just do a wraparound lead shield to protect the baby. A lot of times the thought process is, in very early stages where the fetus is developing, we really don't want to subject them to any radiation. But later, when the baby could survive outside of the womb, we could potentially be x-raying that baby. So the benefit has to outweigh the risk, but there's no cut or dry 100%. Nope, we don't x-ray if they're pregnant. It's just going to depend on the circumstances. So we use lead aprons. Lead is very dense and it can absorb 100% of the x-rays that are passing through it. They're very important to use, especially if you're in the room with the x-rays or if you're in a surgical suite where they're using a C-arm, which is producing x-rays. You want to make sure that you're using those. Exposure, we want to limit the exposure, the lowest dose we can possibly use to get a good quality image. And we also use distance. Keeping that x-ray beam further away from the patient is going to lower their dose. Anybody who works around radiation, so radiographers, radiologists, sometimes nurses and doctors that are in the room with radiation, they're particularly sensitive to the hazards of that constant exposure, right? So we use specialized film badges that monitor the amount of radiation we receive. So it's sent out every month, every 3 months, and if our radiation levels get too high, they would make us stop working. But like I said, with the new equipment, we can control those beams, and the dose methods that we use are so much smaller that the dose we're actually giving the patients is minimal. Patient perspective for general x-rays is usually very easy. I mean, with kids, they can tend to be a little afraid or nervous. Anything that involves needles can make people nervous. But most of all, general x-ray seems pretty easy. There is no prep with general x-ray. Other than getting the patient changed, they don't have to have any additional prep. They don't have to worry about what they eat or drink or anything like that. There can be some modesty issues with those gowns. If you've ever had to wear one of those hospital gowns, you know they're not covering everything most of the time. So be aware of that. You're going to have some patients that do not care. I mean, I have had patients that are in the middle of the hallway and I'm starting to explain to them what they're going to need to remove for the x-rays, and they start to do it in the middle of the hallway with people walking by, and I'm like, no, wait, let's get into this dressing area. So you'll have everywhere from that where patients don't care and they'll start stripping down in the middle of public to patients who are very modest. So the way I look at it is you're never going to offend somebody who isn't modest, but you will offend somebody who is. So treat everybody as if they are a modest individual and give them the ability to make sure that they're completely covered. If they don't care, at that point that's on them and you've done everything that you possibly can. You may also have patients that don't want to change. And that happens, especially people who have had x-rays before. You'll get them in and you'll tell them what you need to do, and they'll say, well, I didn't need to change last time. And usually I just talk them through them. Well, maybe you had a different x-ray last time, or maybe what you were wearing last time was acceptable, but right now I need you to change because One, maybe they have buttons. I need you to change because you have buttons on your shirt, or these pants have a zipper, or the sequins on your shirt are going to show up on x-ray. I'm just trying to get the best x-rays for you so the doctor can diagnose what's going on. When you turn it around and make it about them, usually they don't argue too much. I have had a few patients that are like, I'm not changing. And then I just tell them, well, I'm sorry, I can't do the x-rays if you don't want to change. I understand your frustration. I understand you don't want to change. But if I send x-rays to the radiologist with your buttons or snaps or zippers, they're not going to read them. So I don't want to subject you to that radiation for no reason. Our radiologist won't allow it. And then usually they will change. You just got to realize it's not personal. It's not something that, you did. Just try to walk them through that and reassure them, give them your reasoning, and the bottom line is to try to appease them and get the x-rays that you need. Emergency x-rays can be a little bit different. These people can be in pain, right? The patient comes in from a car accident or a gunshot wound or something along those lines. They're in pain. There's a fear or anxiety factor. And one of the biggest things with fear and anxiety is it usually comes out of the patient as anger. And that's a hard thing for a lot of people to understand is they think, well, why is this person mad at me? They're probably not. They're probably just really scared and upset. So try not to take that personally. Try to listen to them. Try to hear them. And try to talk to them. I'm sorry, I understand you're upset. I know you're nervous. I'm going to try to get the best x-rays I can in the shortest amount of time, limiting your movement to try to help you get through this. Let me know if there's anything I can do for you. Just giving them a little bit of understanding and compassion can really change things. I've worked with a lot of people, and I try to be as compassionate as I can, but I've worked with people who are like, you know what, it's not my fault that you're here. I'm just trying to do my job. Well, that's going to cause friction. It's going to cause that patient more fear, more anxiety, and then they're really going to be angry. That's not helping the situation in any way, shape, or form. And again, there's the modesty issue. Hopefully none of you have ever been in a traumatic situation or an accident, but if you have, they might need to cut off your clothing to assess you or to treat you. So modesty kind of goes out the window in those situations. We do the best we can, but at that time, modesty is not our concern. This patient's injuries, illness, or them living or dying is our immediate concern at that point. The cost for x-ray is relatively inexpensive. It's actually one of the cheapest diagnostic imaging modalities there is. So a hand can be as cheap as $60 and an L-spine $400. I know that sounds like a lot. That's a lot of money for me, but in relation to the other modalities, it's fairly cheap. In some institutions, the radiologist may charge an additional fee for actually reading the images. So sometimes when you go in, or patients go in, they might get a bill for their x-ray, and then they might get a bill from the radiologist for reading it. Who's performing your x-rays or your general radiography? Hopefully, a registered radiologic technologist. So for someone to become registered, they need to graduate from an accredited associate's degree or bachelor's degree program. It's really important to know whether the program that you're going into is accredited. Jackson College holds their accreditation standards very high to make sure that we're accredited through the different organizations, because what happens is you could go through an entire program, and if they're not accredited, you might not be able to sit for your board exam when you're done. So you go through and you do your college core curriculum, which are classes you're taking like DMS 100, and then you're going to do 2 years of clinicals and didactic courses that relate to radiology. So it's essentially a 2-year program. You might have to do your core basic classes prior to that. After those 2 years of clinicals and your didactic courses relating to radiology, you're going to sit for your national board exam, which is given through the ARRT, the American Registry of Radiologic Technologists. Once you pass that board exam, you'll become a registered radiographer, and you'll have the initials RTR after your name. So I would put my name as Stacy Van Riper, And then after Stacy Van Riper, I would put RT and R, like just like this. What that's saying is I'm a registered technologist in radiography. So, if you're ever possibly asked on a test what the proper initials are for a registered technologist, make sure you remember this, RTR. And again, they're registered through the American Registry of Radiologic Technologists. Technologist perspective can be completely different. One, it's going to depend on that person's attitude, right? We all have different perspectives, and most of it's dependent on our attitudes and how we feel about things. But I personally, and I know a lot of other technologists, find the work very rewarding. We get to help patients. We may be the first person that finds their cancer, the disease that they have. And it's very hard because we can't say anything. But we are also the first person to see after treatment if their cancer is gone. We can give them a lot of compassion and care in a small amount of time, which to me is very rewarding. If I have a patient that's scared or upset or nervous, there's nothing that I take more pride in and enjoy more than trying to give that patient some care, some compassion, a little glimmer of hope to make their experience a little bit better. As a technologist, we have the power to make their situation better or worse by how we act and how we take care of them. And that's something that I'm very passionate about. Sometimes it can be routine. You know, if it's flu season, we may do 100 chest x-rays a day. Now, every chest x-ray is going to be slightly different depending on the patient's condition and age, but it can be a little routine. It's nice to help people. It really is. You know, if a person tells you thank you or I appreciate your help, it makes you feel good too. It can be exciting. Now, my dad always told me that it was wrong that I got excited over other people's misfortunes, and I wasn't excited that people were injured or hurt, but to me, seeing some of those broken bones or injuries on the computer screen was exciting. And I know that there's slight problem with that, but I'm not happy they're hurt. Let me clarify that. It can be grotesque. You can see some pretty crazy, gnarly things. Not too long ago, I had seen a patient who had just had a recent knee surgery, and for whatever reason, they decided to go out on the ice to sit with their friend while they were ice fishing. So they stepped out on the ice, took a few steps, slipped, fell, busted open all of their sutures from their surgery, and their entire knee was laid open, and I could see all the bone, the metal from the replacement, and all that. That was probably one of the craziest, grotesque, kind of cool things that I've seen. Coping with people. Again, that's going to depend on the person. You know, they may be depressed. They may be scared. They may have a lot of anxiety. There's a lot going on with those patients when they're coming in for radiologic procedures. So we need to be a source of comfort for them. It can be depressing. I mean, I've had days where I've left the hospital after I've seen a 12-year-old that possibly had cancer, a woman who had a huge tumor in her lungs. I mean, I've left the hospital having 5 patients that day that I've seen have horrible things wrong with them. And that can depress you, right? Especially if you can relate it to your family members or your kids. But those are few and far between days. You know, we feel for our patients, so we're going to absorb a little bit of that. It can be risky, slightly. I mean, we can be exposed to hepatitis, HIV, other viruses, things like that. So, you know, any hospital job at all, you're going to put yourself at some slight risk. But overall, it's going to depend on your perspective. I love what I do. It's very rewarding to me. It makes me feel good when I can help patients. It's exciting to me. So my perspective might be a little different than somebody else's. There's some different career advancements potential in X-ray. You can become a chief technologist or a manager. You can go into sales and applications. There's actually people who travel around when x-ray departments get new equipment, and they'll teach them how to use the new equipment. And you can go into education like me. I actually used to be a clinical instructor for the radiography program in the hospital. So I worked at the hospital, and I would have students come in, and I would work with them for those 2 years and train them how to become radiographers. Compensation is going to depend, one, on experience. So new graduates are going to get paid less than somebody that's got 10, 20, 30 years of experience. Also, your geographical location is going to affect. I mean, technologists in Jackson, Michigan are going to get paid less than technologists working in San Diego or New York. I mean, bigger cities are going to be paying more, but the cost of living is higher, so there's kind of that offset. The average pay scale is about $24 to $29 per hour. 29 is not the cap. I know for a fact that technologists can make more than that, so that's not the cap. That's just the average pay scale. You also will get benefits. You usually get health, as either part-time or full-time employees, usually get health care, optical or dental. You can get a 401k or possible pension depending on where you work. And you have PTO, which is paid time off. There are some ethical issues that are a concern when it comes to radiology. One is mainly just unqualified people who are performing x-rays. Like I said before, it should be a registered radiologic technologist that's taking your x-rays, but sometimes in chiropractic offices, small doctors' offices, places like that, they have MAs or nurses, or even the doctors themselves are performing the x-rays. That doesn't mean if a doctor's performing it that it's still of good quality. There's been times where I've walked into an OR suite and the doctor was so impatient they couldn't wait for me to get in there that they had one of the nurses trying to press the buttons for the x-ray. That's not acceptable. We can't have that happening. That's an ethical issue. Future of the modality. If you look in your lecture book, it's going to tell you digital x-rays are the future. Those aren't the future. They're here right now. Some of the future that we've seen coming out is full color 3D x-rays. The x-rays aren't actually taking images in color, but we can apply color afterwards to help differentiate between tissue, muscle, bone, things like that. And there's also an EOS system, which is a full body x-ray. I have a video on JetNet as well that you can kind of watch. They use it a lot for scoliosis, but they can do 3D models of it afterwards. So if the patient has to go in for surgery, they've got a 3D image that they can really help reconstruct that spine. Here's some websites and phone numbers if you have any additional questions about radiology. And right now what I'm going to do is end this here, and then I will start a second one that goes through some of the x-ray images.